point is not clear or that point is to be cleared with more clarity, so in that case you can stop me in between and you can ask the question. So madam, should I start or should we wait for a few participants, or we should start?
Sir, we have to wait for 5 minutes because some
Okay,
students,
okay,
just
madam.
for 5 minutes.
Okay, madam. We are waiting.
Interns, anyone left now?
I will try to make assessment more clear with you, but still, as we are not in front of each other, so if you have any doubt, you can stop in between and we can discuss the question answer. Clear? So, is it okay for the students?
Yes, sir.
Yes, sir.
Am I audible to all?
Yes, sir.
Yes, sir.
Okay, fine. Okay, fine. So we are starting with the stroke assessment. So as all of we know, there are actually separate assessment formats, institute wise also. So but few common things those are there. So definitely we should discuss first in brief and then we will go for on examination part. Clear? So first of all, name. So we are asking the or documenting the patient's name for the documentation purpose and for the identification of patient. Definitely in documentation, actually if the patient is having mediclaim, so we should always ask the patient for mediclaim, and if the patient has mediclaim, our case paper should exactly reflect the same name. Is this clear? Otherwise many times later on the queries they are coming that this name does not match or likewise. So we should always take care that patient name is as per their mediclaim or as per their any ID card. Clear? Okay, then age and gender. So what is the purpose of asking age and gender? I want answer from students only. Why we are asking age to the patient? Hello?
Students, please give
Hello?
the answer.
Students?
Is it audible to everyone? Is it audible to everyone? Students, you can give
Okay.
answer in
Yes, sir.
between.
Yes, please give answer.
But certain diseases are in certain age groups. That's why age is
Very good.
necessary.
Very good. Okay, so for diagnosis purpose as well as for prognosis purpose. Prognosis means what? We have to forecast the progression of the disease or we have to forecast the recovery of disease. Now the gender. So gender is also to be documented. Now for the stroke patient, it is interesting to know that males, they are having earlier onset of stroke. Means as compared to female, males they are getting stroke at the lesser age. Okay, but they will be recovering well. On the female part, they will be getting stroke at the later age, means 5-10 years average later as compared to male's age, but they will be having poor recovery. Clear? So gender has impact on occurrence of the disease as well as its prognosis. Clear? So the gender wise, males they have earlier onset but good recovery. Females they have later onset but poor recovery. Now coming to address. So why we are asking the address? So that is not to be to send a happy birthday card or any invitation to send to patient, but many times I have seen that many students they are also writing pin code in address, but actually it is not needed. Why the address is required? Address will guide us that what should be the frequency of patient visiting the physiotherapy department. If the patient is coming from miles away, okay, just for your assessment, So in that case, we are not supposed to call the patient on daily basis. On the contrary, we can advise the patient that you visit the nearby physiotherapy department. Okay, address will also help us to decide that whether the patient will be able to continue job or not, because the mode of transportation and everything is to be advised. Clear? So address is important to know so that we can give few advices regarding their visit to physiotherapy clinic as well as regarding their visits to their job particular places. Then occupation. So occupation, why it is important to ask in assessment? Because occupation wise we will be deciding the treatment protocol. Clear? Whatever you do after your neuro rehabilitation, like you are increasing strength, you are increasing range of motion, you are improving the quality of movement. So in that case, it is not sufficient. Patient must be back to work. Patient must be back to work. So if we know the occupation, then definitely we can advise accordingly and our treatment plan will be focused on that. For example, if the patient is security person, okay, so he needs to stand, so basically we should work more on standing. Okay, if the patient is typewriter, so we should work on dexterity of fingers. Okay, so it is based on our treatment plan, it is based on patient's occupation. Then provisional diagnosis. So what do you understand by provisional diagnosis? I want to answer from the students. See, there is no punishment if you give wrong answer. Let it be interactive.
Students answer
Yes.
what they say.
Yes.
Even if you say wrong, students answer the question. Even if it's wrong, it's okay. We don't mind with
There is
that.
no punishment. There is no punishment for wrong answer.
You can just give a try, because only giving a try you'll be able to learn. So just give a try. It's okay.
I think I should ask with name. Anjali, Vanjara Anjali. Upasna.
So without any investigation or without any examination, मतलब एक डायग्नोसिस ऐसा जो या तो पेशेंट के आने से और उसके थोड़े से ही बोलने पे हमें मतलब पता चल जाए कि like he is or she is
Very good.
having this kind of.
Very good, very good. So provisional means it is temporary diagnosis. But if the patient has come with the definite diagnosis, for example, patient has already come with the CT scan and MRI report, and it is also mentioned in the patient's discharge summary that this patient is having stroke left side or right side. Okay, so whatever. So it will not be considered provisional diagnosis. It is only diagnosis. That's it. Clear? Okay. Then comes
Okay, sir.
dominance. So dominance means what? Anyone? What is dominance?
Hand dominance.
Yes, okay. Hand dominance. It will be also there for leg also. So many times, for example, at present, I have one patient. Okay, he is having left hemiparesis at present, but he was doing all of his work with right side. Okay, he is magistrate, so he needs to do a writing process more. Okay, and he needs to speak. So both are preserved. Okay, so the only problem arises when he needs to use two hands simultaneously. For example, driving a car, or for example riding a scooter. Clear? Otherwise he is independent in all of his activity. So the dominance matter. Okay, his dominant side is right side. Okay, stroke is also affecting right side of the brain, so left side of the body. So the activity of daily living is not affected much except driving a car and riding a scooter. Otherwise he is doing all of his activities, even though he is not having enough power, enough range, and is not having good voluntary control in left side. So dominance is very important, because if the non-dominant side is involved, patient is less disabled, and if the dominant side of the body is involved, patient is more disabled. Okay, now how to decide this dominance? Anyone? How to decide this dominance? Pallavi. Pallavi, your madam. Okay. Rashmi Jadeja, you are student. Rashmi.
Yes, sir.
What is dominance?
Dominance is a righty or lefty.
Yes. Okay, fine. So you are righty or lefty?
Righty.
Righty. Okay, fine. So just for example, if I ask you a question like this, that I am eating with my right side, writing with my left side, putting a ball or throwing ball with my right side, okay, then drawing a circle with left side. So what will be the my dominance?
Left side.
Okay, how can you say left side? Okay,
Um,
many times it, okay, let me answer. Actually, many times it happens that a person will be doing few activities with right side and few activities with left side. So how to decide? So for that we have one inventory, so that is known as Edinburgh handedness inventory. Clear? This is easily available in Google. You can search this. At present, if you have no any instrument to write, you can have screenshot of it. And so it is nothing but Edinburgh handedness inventory, what it is. So for example, if we have one student with us, okay, so for example, writing. So how to score this? So writing means, for example, if I am talking for me, so if I am writing always with my right side, okay, I will always compulsorily use my right side for writing. So I will put 2 plus under the right and 0 under the left. Clear? For example, second process is drawing. So I will compulsorily use my right side, okay, to draw something. I will never think of using my left side also. Clear? So I will put 2 plus in right side and 0 in left side. Now throwing a ball. So it is just preference. It is not compulsory. I will prefer my right side to throw the ball, but I can also throw with the left side. Okay, but it is my preferable side, right side. So 1 plus. If it is compulsory, it is 2 plus. If it is preferable, okay, then it is 1 plus. Under the right, 0 under the left. Okay, for example, scissors. Okay, so to operate the scissors, I will be indifferent by using right side as well as left side. Clear? So I will be doing the scissor activity with my right side, as well as I can also do with the left side. Okay, both are same for me. Then 1 plus under both, under right side 1 and under left side 1. Are you getting this? Clear? And few activities, they are bimanual activities or bilateral activities. So in that case, for example, brooming. Okay, so that is not, brooming means whatever we are doing for cleaning the floor. Clear? So in your upper hand, if it is upper hand is right side, it is dominant. For example, striking a match. So for example, if you hold match box with the left side but match stick with the right side, so right side is your dominant. Clear? So we are not deciding just based on one or two activities. We have to ideally take all this 10, and as I told, if it is compulsory, put 2 plus under any side, right side or left side. If it is just preferable, put 1 plus, okay, under right side or left side. If you are indifferent, indifferent means you can do with both the sides, okay, equally, then 1 plus under both, under right side as well as left side. And for bilateral activity, okay, or bimanual activity, so whatever it is given in the brackets, for example, opening a box or opening a jar, so whatever the hand you are using for opening jar, that will be your dominant side. Clear? And ultimately you go for total, and whatever the side is having maximum score, you will be having that side dominance. Is it clear?
yes, sir.
Yes, sir.
Okay, fine. Now the socio-economical conditions. So for that
Sir,
we have one
sir,
yes, please, madam.
sir, can we add one poll?
Yes, please, madam.
Okay, sir. So one question will be there. So you have to ready and give answer.
Okay. Now should we proceed?
Yes, sir.
Okay, fine. Now the socio-economical condition. Very good. 100% correct
100%
answer. The
correct.
students are active. Actually, they are not giving answer. So I thought that they are just doing this formality of attending. Okay, because of fear of madam, but it is not like that. Okay, then laboratory reports. So what will be the commonly seen laboratory reports for the stroke patients? I would like to get answer from the students. Which are the commonly available reports with the stroke patient? Yes. Any student? Maitri Trivedi or Nancy?
Yes, sir.
Huh. Yes, Maitri or Nancy?
Yes, sir.
Give the answer of Maitri.
Sir, MRI, CT scan.
Nancy.
Sir, MRI, CT scan.
Very good. MRI and CT scan. Very good. Okay. Generally, let me explain. Generally, when the patient is having stroke, okay. For example, Nancy. Okay, be unmuted. If stroke occurs in front of you, okay, are you listening?
Yes, sir.
If the stroke occurs in front of you, okay. So, what will be your first step? What you will do?
Sir, શું કીધું?
If any person in front of you has stroke, okay, so what you will do first?
Sir, first of all, BP and diabetes.
Okay, see,
અને પહેલા હોસ્પિટલ
hello,
કેમ લઈ જવાના?
yes Nancy, yes, very good. Patient should be sent to
Hospital.
hospital. Stroke cannot be managed at home. Clear?
Yes, sir.
So which hospital? So that hospital must be having facility of CT scan.
Scan and MRI.
Clear?
Yes, sir.
So MRI is less available. MRI centers, they are very less, but at least CT scan facility should be available. Clear? So whenever the stroke occurs, patient should be sent to hospital where there is facility of CT scan. So CT scan is able to identify the lesion within 6 hours of onset. Clear? MRI will be able to detect after 24 hours. So we cannot wait for 24 hours. Clear? CT scan will be just giving presence of this infarct. It will not be able to identify the exact infarct size and infarct location. So when you see the CT scan report, so it will be just written like that. Patient is having hemorrhagic or ischemic type of stroke. Okay, infarction. But they will never be mentioning the size and location with details. But when on the second day, patient will undergo for MRI, then you will be having exact localization of site of lesion. Exact localization will include, okay, infarct is present in posterior genu and posterior limb of the internal capsule, etc., etc. Infarct is present in basal ganglia, likewise. Clear? So MRI will be able to identify the exact infarct location. Clear? So CT scan and MRI, those will be the commonly found with our patient, and we have to do with that only. We have to identify the information. Second thing is we have to read the discharge summary of patient, because almost all the patients, they will be having hospitalization. So it is always advisable to read the discharge summary. So discharge summary will include everything, including laboratory reports, including patient's history, clinical findings, and everything. Clear? So it is advisable to read the discharge summary. Okay, referred by. So generally, see, patient is having multiple doctors in their course of stroke rehabilitation. First of all, when the stroke occurs, patient goes to neurophysician, then patient will be hospitalized and patient's vitals will be made stable. Patients will be discharged from the hospital when the vitals are stable. Vitals means BP, temperature, heart rate, okay, respiratory rate, all this will be affected. So especially BP. So when the blood pressure comes down and it will be normal, patient will be discharged. Clear? So after that, generally patient goes to visit of neurophysician only one or twice. Later on, the general physician will take care of patient and physiotherapist will take care of patient. So if you know that who is the reference or who has sent the patient, so if there is any problem related to rehabilitation or you're not getting good recovery, then you can discuss with this physician, neurophysician and general physician. And chief complaint of the patient should be always asked in our assessment, because the thing is our treatment plan should always focus on patient's complaint. Clear? So if the patient has more complaint of that I'm unable to walk, so we should give more emphasis on walking. If the patient has more complaint of writing issues and typing issues, so we should work more on upper limb, okay, especially fine motor skill. If the patient is cashier, so he has to sign many times in a day, so we should work on his writing. Okay, so it depends. For example, if the patient is driver of the taxi, so we have to plan our treatment accordingly. So whatever the patient's chief complaint is there, that I'm unable to do this, I'm unable to do that, so that should be listened carefully and that should be documented also. But the thing is, complaint should be always in patient's own words. Okay, whatever the patient speaks, you have to write down. It should not be in medical terminology. So I think that up to this you are clear. Okay, students?
Yes, sir.
Yes, sir.
Okay, fine, good. Now the history. So it is told that perfect history, 90% diagnosis done. Perfect history taking makes it possible that 90% of your diagnosis will be done. So you have to go for present medical history, past medical history. Now, what is the difference between present and past medical history? Students. Pooja Solanki. Pooja. Pooja is there or not?
Student, is it
Yes,
audible?
sir.
Pooja, yes, yes. Pooja was taking dinner, but we disturbed her. Okay, Pooja, you can give answer. What is
पेशेंट को
difference between present? Yes, yes.
पेशेंट का पेन जब प्रेजेंट होगा तब प्रेजेंट हिस्ट्री ले जाएंगे.
No. See, okay, no problem. See, present history means that is continuous course of any condition. For example, if the patient had a stroke before 6 months and patient has not recovered yet, clear? So patient is still under treatment. So it is coming under present medical history. But if the patient had TIA, transient ischemic attack, before 2 months, patient was fully recovered. Okay, now again the patient has stroke after the 2 months. So that TIA comes under past history. So in short, patient should be 100% normal between present and past history. It has nothing to do with duration. Present medical history may be extended up to last 6 months or 1 year, and past history may be only 2 months old. That is possible. Clear? So in short, patient should be 100% normal between past and present. Okay. Now personal history. So personal history, we should discuss, like it is like lifestyle or smoking or addiction of alcohol, etc., because also our recovery. And family history. So if any person in family has suffered from the stroke previously, so there are more chances that the person or individual with this family history positive may get stroke. But what is the effect on recovery? Okay, that is not still clear. That, for example, any person of the stroke has family history positive of the stroke, like his father or mother had stroke, so the chances of stroke are more. But whether it is affecting recovery or not, that is not yet clear. But still we should ask the family history so that we can warn the patient, okay, for the second time stroke. Always consider that if the person is having stroke one time, there are 3 times more chances of having stroke again as compared to normal individuals. Clear? For For example, if I compare myself with any stroke individual, so that fellow has more probability of getting stroke again as compared to me. Clear? So you can warn like this. Okay, so if you have family history, you have more chance of getting stroke again also. Okay, so be careful. Now,
Sir,
observation. Yes, please.
if पेशेंट 2 ईयर पहले स्ट्रोक हुआ है पेशेंट को, ठीक है, और उनको अभी तक रिलीव नहीं हुआ है, तो वो प्रेजेंट में आएगा कि पास्ट में आएगा?
प्रेजेंट में ही आएगा, रश्मि.
अच्छा, ठीक है.
Okay?
हाँ, यस सर.
So
थैंक यू सर.
present and past means patient should be 100% normal in between. Clear?
Yes sir. Yes.
Fine.
Okay,
Now
thank you, sir.
observation. So yes, okay, fine. We will be having a brief part of the observation also, and then we will go for examination. That is actual part of today's learning. So posture and attitude. So we should always consider the patient's posture, because many times this posture may lead to further problems. So posture should be assessed in lying, sitting, and standing. For example, if you go for ICU, so only the lying position will be possible to assess. Okay, then if you go for ward, so patient may be able to sit also. Clear? So it should be assessed in lying as well as in sitting. And for further progression wise, patient may be standing also, patient may be walking also. So we should also check in standing position. So posture and attitude, that should be assessed in whatever position out of this three it is possible. Clear? Okay. Now this posture will also help you to prevent further problems, like if the patient is leaning to one side, mostly on affected side. Okay. So patient may develop scoliosis. Okay. Patient sometimes may develop pusher syndrome also. Pusher syndrome means normal side will be used to push on affected side. Clear? So that is also there. Many times because of this posture, because this hanging of the upper limb is there, so there are chances of subluxation of shoulder. Clear? So all these are very important to know, so you can prevent the further complications. Vesting. So again, there should be one question from the student side. Okay, that why the vesting occurs in CNS. We are already taught from our first year BPT that vesting occurs in lower motor neuron disease. It does not occur in UMN disease, upper motor neuron disease. But vesting may be present if your problem persists for more than 1 month or even more. Clear? Because of disuse atrophy. So always remember the principle of our body. If you don't use it, you will lose it. I repeat, if you don't use it, you will lose it. If you don't use your muscle, you will lose the strength. If you don't use your muscle in full length, you will develop tightness. If you don't use your brain, definitely you will lose your memory. Clear? If you don't use your joint, definitely you will be having stiffness. So if you don't use it, you will lose it. So always use it before you lose it. Clear? Always remember this for you as well as for your patients. Clear? So vesting will be there just because of disuse atrophy, but it will not be seen immediately. It will be time taking process. Okay, generally it will be visible or marked after 1 month of illness. Then trophic changes. So that is nothing but skin related changes. So many times we have bed sores development and callosities. Callositis means it is blackening of the skin because of continuous friction. Clear? Involuntary movements, generally they are not present in most of the stroke patients, but still it is our duty to assess, because the patient should be assessed as a whole. Patient is not assessed focus wise. Okay, like if the patient comes with stroke, then it is not our duty that we should focus only on infarct size, infarct location. Okay, patient should be assessed as a whole. Many times we will find something that is actually not written in our discharge summary. Clear? So it should be always assessed as a whole, including involuntary movements. If the patient is having swelling or particular area, so that may be possible because of bedridden condition, or sometimes the hanging limbs, lower limbs especially, sometimes also in upper limb. So this swelling should be assessed, so you can take precautions to prevent it. Now external aids. So what are the external aids? Students, I want to answer. External aids. Anyone? Indra, roll number 48.
Yes, sir.
Yes. What are the external aids those you expect from stroke patient?
Because of the loss of muscle contraction and weakness of muscles. That's why they should not walking.
No, what are the external aids those you will be finding on your patient? If you go to ward or ICU or patient's home, you are doing visit. Okay, I know that you are doing visit. Okay, so if you are going for a patient's visit at home, so which are the external aids that you will be finding on patient's body?
Like the tripods,
Okay, stick.
yeah,
Very
sticks,
good.
monopod.
Okay, fine. Okay, so it proved that you are going for visit. No problem. So generally stick, just I'm laughing. Okay, stick. Then sometimes if you go for ICU, so there will be splints also. Then sometimes rice tube. So that will be also considered as a external aid. Clear? For example, if you use the shoulder support. So all these are examples of external aids only. Then psychological features. So generally for all the chronic illness, especially after the 6 months, it is observed that the people, they are developing some kind of psychological illness features like stress, anxiety, depression. Okay, so if it is at the low level, definitely we should assess and we should try to tackle, but in severe cases we should send the patient to psychiatrist. Clear? So referral practice is also very important. Clear? It is not like that we know everything. Clear? Whatever we know we should try, then we should refer the patient to specialist or expert. Okay, then higher functions, so those include consciousness. So when you go for any patient, especially in hospital setup, so in discharge summary or sometimes even in cases, you will be writing this, you will be reading this Glasgow Coma Scale. So how many components are there in Glasgow Coma Scale? 3 components are there. Which are they? Vishal, roll number 13. Vishal.
Yes, sir. Glasgow Coma Scale, sir.
Yes. There are 3 components.
Sir, eye-opening response.
Okay. Response, then
verbal
response and motor response. Very good. So in your case paper, many times you will be reading this like E2, V3, M3 means eye response is at 3 level. Okay. Motor response and verbal response at 3 level or 4 level, whatever it is written. For example, E2, V3, M3 means eye response to verbal and motor response 3. Minimum is 3 and maximum is 15. Okay, minimum is 3 and maximum is 15. Less than 8 score, it is not normal. Clear? But more than 8 score out of 15, it will be normal. Okay, it will not be having major issues. Then memory. What is memory? Anyone? Memory means what? Riddhi, roll number 14.
Yes, sir.
Memory means what? What is memory?
Memory means अगर पेशेंट को स्ट्रोक आया है तो उसके बाद में हम उनको कुछ क्वेश्चन करके पूछ सकते हैं कि उनकी इमीडिएट मेमोरी कैसी है। इमीडिएट कुछ हम कुछ बोलेंगे, फिर उनको रिपीट करने के लिए बोलेंगे। अगर वो रिपीट कर पाते हैं तो उनकी मेमोरी, उनकी इमीडिएट रिकॉल अच्छी है। उनकी शॉर्ट टर्म मेमोरी और लॉन्ग टर्म मेमोरी ऐसे ही हम उनको रिकॉल करवा सकते हैं और टेस्ट कर सकते हैं।
What is short term memory?
शॉर्ट टर्म मेमोरी मीन्स सर एक या 2 दिन पहले की उनको कुछ बात पूछेंगे
क्या खाया,
और लॉन्ग टर्म मेमोरी मीन्स
कल आपने क्या खाया, कल रात को क्या खाया आपने?
सर कल रात को तो डिनर में
डिनर तो बराबर, क्या खाया? शॉर्ट टर्म मेमोरी इज अफेक्टेड। Vidhi.
Yes,
Are you
sir.
remembering? Okay. What did you eat yesterday in dinner? Hmm. You are not recalling, or you don't want to share with all.
Yes,
Is
sir.
it so? Is it so? You don't want to share?
Yes, sir.
Okay, fine. Okay,
Yes,
no
sir.
problem. Okay, so I had sandwich yesterday, so means it is short-term memory. See, okay, it is good. Vidhi. Now, immediate recall means it is lasting for few seconds only. Short-term means it is lasting for few minutes, hours, or days. Okay, so she already told that for 1 day or 2 days, so that is also fine. Okay, short-term memory lasts for few short-term memory lasts for few hours and days and sometimes minutes also, and long-term it is for months and years. So immediate recall lasting for few seconds, short-term for few minutes, okay, hours and days. Long-term it is for more than months or years. Clear? So long-term, for example, if you ask me that what is the name of your school, clear, so it is long-term memory before many years. Okay, so this is the memory what we are checking. And in short, if we give definition of the memory, so it is the ability of the individual to store the information and experiences to recall later. Whatever, so it is nothing but storage of information and storage of experiences. Then speech. So our patient may be having Broca's aphasia, then Wernicke's aphasia, but frankly speaking, Wernicke's aphasia patients, they are very less. Most of them, they are having Broca's aphasia. So Broca's aphasia means they will be having problem in expression. For example, and Broca's aphasia, you observe most of the right hemiplegic patient, they will be having speech problem. Okay, if the patient has affection of right side of the body, speech will be affected. And if the patient has left side of the body involved, so proprioception will be affected. Clear? So this is to be taken care of. So speech will be affected in most of the right hemiparetic or hemiplegic patient. Okay, so Broca's aphasia means they know what to say, but they have problem in expression. Clear? For example, if you show the mobile and ask them what is this, so they will not be able to pronounce that this is mobile. Okay, they will try to speak something, but that is wrong answer. Sometimes they are not giving answer. But if you say, okay, is this mobile, so they will be definitely give answer that yes by nodding their head. Clear? So they know, but they have problem in pronunciation. Okay, they have problem in expression especially. Clear? Okay, so these people will be also having problem in calculation. These people will be also having problem in gestures. Clear? Ultimately these expressions, they are affected. Okay, it may not be just in form of the words. Okay, it may be in form of gestures also, it may be in the form of sign language also, and calculation is also affected. Clear? And in case of Wernicke's aphasia, the patient's fluency and everything is very normal. Patient ની લેંગ્વેજમાં કહું તો પેશન્ટ એવું બોલશે કે સ્ટ્રોક આવ્યો ને પછી બેરા થઈ ગયા છે. Okay, અમારું સાંભળતા જ નથી. So what does it mean? It means that the patient is not listening. Okay, even though whatever he or she wants to tell, they will share immediately. તમે એને પૂછો કે ભાઈ ખાવું છે, if you ask खाना है तो वो लोग आंसर नहीं देंगे, पर उसको खाना है तो डेफिनेटली बोलेंगे कि भाई मुझे खाना है, एकदम क्लियरली बोलेंगे. Why? Because it is internal drive. Okay, that is allowing him to speak. But if you ask, they will not be understanding your question. Okay, so that should be assessed. In case of severe speech problems, you should refer the patient to speech therapist. And as we discussed, speech is not just pronunciation, it is also affecting your reading and writing ability. Clear? Then orientation. So orientation, we have to ask for time, space, and person. Clear? So I think that all of you are getting disorientation during your classes. That is very common. Clear? So if you are aware about the time, for example, we will check orientation of one student. Jatin, rule number 65.
Yes, sir.
Jatin, there?
Yes, sir.
Fine. Jatin, okay, what may be the time now?
7:21.
Okay. He's perfect. But still,
Okay.
if he tells that it is evening, then also it is time orientation, that is normal. Okay. Where are you now?
Home, sir.
Home. At your home or friend's home?
Sir, my home.
My home. Okay, so he's aware about the place. He's aware about the space also. Okay. Do you recognize me? What is my name or who I am?
Yes, sir.
Okay. Can you give me my name?
Dr. ASHISH KAKKAD.
Okay, fine. So he knows me. Okay. It's not like that every time he should recognize me. If he is able to answer his familiar faces. Okay. Thank you, Jatin.
Okay.
So if he is able to answer the familiar faces, because they are not in presence of us at present, otherwise we can show the patient's relative and ask the patient that who is he or who is she. Okay, so that is nothing but time, place, and person orientation. Now, sensation. So sensations will be superficial sensation, deep sensation, and cortical sensation. So what are they? What is superficial? What is deep? And what is cortical? Kiran Jain. Kiran. I think Kiran is in kitchen. Kiran Jain. Okay. Yes, she's there. Kiran. Yes. What is superficial sensation? I think there are some technical issues with her. Kinnari. Patel Kinnari. Yes, please. Yes, please. I think she is searching from book. We can listen the sound of pages. Yes, please.
Hello, sir. Touch,
Yes.
pain, temperature.
Okay, fine. Okay, fine. May I ask that what you are doing?
मैं
You are
बोल रही
riding
थी
your
पर मेरा
vehicle.
नो सर
Okay.
एक्चुअली सर मेरा नेटवर्क नहीं आ रहा है ना यहाँ पे गांव में इसलिए
Okay, fine.
मैं
No
बोल
problem.
रही तो सर
Fine. So superficial sensation means the stimulus will be coming from outside of your body. See, it is very simple to understand. Superficial sensation means the stimulus is coming from outside the body and it will be just on your superficial part of the body. Like the receptors will be present over the skin mainly. Clear? And that will be a superficial sensation. Then comes deep sensation. So the stimulus comes from inside the body, like joint position, joint sense. Clear? So that is deep sensation. Okay, and that will be identified by the structures. Those are available within the joints and capsules. Okay, and cortical sensation. So cortical sensations means they will be developed with experience. In the newborn baby, these cortical sensations will not be present. Okay, it is always developed with experience. Now, superficial sensations that include, as Kinnari told, fine touch, crude touch, thermal, and pinprick. So, fine touch. How to check fine touch? Tulsi Parmar. Rule number 25. We will be discussing with Tulsi. Kanisha Parmar. Hello, am I audible or not?
Yes, sir.
So I need answer from you. You are?
In fine touch, sir, we using some cotton or and apply to the patient and tell to the patient ki, is it you are feel or not,
Very good.
and this is doing in a closed eye.
Very good.
Yes, and the group does we are some rough object we are using and touch to the patient.
Okay, do you have any rough object in your hammer? Have you seen that?
Yes, yes, sir.
Okay, so when you
Yes,
open
yes,
it,
sir. Yes.
okay, yes,
In
good.
thermal, we are using the two taste, one hot water and the cold water, and we are apply to the patient, right? And we ask to the patient whether it is hot or cold.
Okay, I think that you are in market shopping something.
Yes, yes, sir. In
Okay,
pin,
good.
yes, and pin prick like tooth speed we are using in sharp object, and we are doing this.
Okay, fine. So she told very well, fine touch, we can use the wisp of cotton, and she told very well that we should ask that whether I have touched or not. We are not supposed to ask that where I have touched. Yeah, that will come tactile localization, that is part of cortical sensation. In fine touch, we are just asking that whether you are able to register the stimulus or not. That's it. Then crude touch. So you have the opposite side of the hammer. If you open it, so you will be having hair on the back side, okay, or on the pointed side of the hammer. So that can be also used for crude touch. Thermal sensation is to be checked with test tubes. So temperature is very important. Temperature of cold test tube should be from 5 degrees Celsius to 10 degrees Celsius, and for hot water it should be from 40 to 45 degrees Celsius. Clear? So for cold it is 5 to 10 degrees Celsius, for hot it is 40 to 45 degrees Celsius. Pin prick, so we all know, but for pin prick, whatever the pin you are using, that should be sterilized. And once you check on the patient, then you are not supposed to use that again. Okay, it may spread the infection. So it should be disposable. Before you check, sterilize. After use, you dispose. Clear? So that is for pin prick. Very good. And she told very well that patient's eyes must be closed. Patient's cloths must be exposed, okay, or part must be exposed, okay, and always compare with opposite side. So these are the three main precautions those we have to take. And you will not believe, but one of my senior, she was doing MPT in neuro, and in her MPT practical exam she got 0 marks. Why? The thing is, the patient was of burns. She checked the sensation without removing the bandage. Clear? And the examiner refused to take further examination. Why? Because she did not expose the part. Even though it is of burns, you can remove that. Okay, if it is not possible to remove, at least you mention that just because of limitation of removing this bandage, I have not checked. But you can never say that I have checked on bandage, I have checked on clothes. Why? Where these receptors are present, they are present on skin, not on your shirt or not on your dress. Clear? Okay, if the patient is not convenient, then also you can tell that patient is not convenient to expose the part. Okay. Okay, otherwise if you are not comfortable, then also you can mention properly that it was not exposed, so sensation was not checked. But in all other cases, it should be with eyes closed, part should be exposed, and always compare with opposite side, because many times there is hypoesthesia on affected side. Clear? And just because of this hypoesthesia, the patient will be able to identify, but when you compare with the opposite side, you will come to know that this is hypo. Otherwise you will come to know that it is normal only. Clear? So always compare with opposite side. Then deep sensation. So it is joint position, joint movement, that is also known as kinesthesia, and vibration. So joint position and joint movement, they are very easy. You put a joint into particular position, or you move the joint in particular position and ask the patient to perform on normal side. If the patient is able to perform on normal side, means he knows what is the position of joint or what is the movement that is done. Okay, for example, if the elbow is in extension, clear, so you move the elbow into 15 degree or 20 degree of flexion. Clear? And then you you can ask the patient to perform on the same side, opposite side, normal side. Okay, so if the patient is able to do, definitely he knows that what is the amount of flexion that you have done. Ideally, we should check on distal joints, okay, with neutral grip. Neutral grip means if we think of the finger and if you are checking the flexion extension at the IP joints, so we should hold from the medial and lateral side of the finger so that the pressure of your fingers will not be able to guide the patient that in which direction you are moving the finger. Yeah, so it is better to check on this side, that is it is better to check on uh, what we can say, it is on distal components or distal joints. Then coming to vibration. So for vibration, we know that different tuning forks they are available. So for vibration, we have to use the 128 hertz or 256 hertz of this tuning fork, and for vestibular now we are using 512 hertz. Clear? So this is for vibration. Then cortical sensation. Madam, we have a poll on this
sir.
slide.
Sir. Oh, 69% 120 hertz.
Okay, fine. So both are correct. Okay, 128 hertz or 256 hertz, both are correct. And for vestibular now we are using 512. Clear? Okay, fine. Now cortical sensation. So as we discussed, cortical sensations will be developed after experience. So we are using tactile localization. So the stimulus is same. Like with the wisp of cotton, we are touching the patient and patient will be answering that you have touched here or you have touched there. So that is tactile localization. Then tactile discrimination. So if I'm touching with one finger or two fingers, that the patient has to identify. Clear? Okay. Then, but for tactile discrimination, there are tables given in Sullivan. So for example, if I'm checking on the palm, so that should be minimum 2 to 4 meter distance. But if I'm checking on shoulder, it should be 4.5 centimeter distance. Okay. Otherwise, even the normal individuals will not be able to identify. Clear? So for palm, the distance is different, for shoulder, hip, okay, knee. So distance is different. So that is the minimum distance that we should maintain between our 2 point of contact. Then and then the patient will be able to identify. Then stereognosis. Stereognosis means you give something in the patient's hand and patient will be able to identify. For example, with my eyes closed, if someone gives me pen, so I will be able to recognize that this is pen. Or if someone gives me mobile, I will be able to recognize with my eyes closed that this is mobile. So that is nothing but stereognosis. Barognosia. So if I'm given one lightweight and one heavyweight in my hand, so I will be able to tell that, okay, this is lighter and this is heavier. Okay, so that is nothing but barognosia. Graphesthesia, so the name itself it is telling, if you write something on the patient's skin, patient will be able to answer. Like this type of the graphesthesia type of the training is shown in one movie, that is Black, of Rani Mukherjee and Amitabh Bachchan. So that is graphesthesia. They are using this by drawing different shapes and by drawing different alphabets on the skin of the patient. They will be able to learn, okay, because they have already problem of vision. So this will be helpful. Okay, then double simultaneous stimulation, it is recently added in literatures. So double simultaneous stimulation means what? The two different regions, they are having contact at the same time. Clear? For example, two shoulders, two elbows together. Clear? So that is double simultaneous stimulation. Okay. Now reflexes. So actually there are many classifications for reflexes, but the clinical classification falls like this: superficial, deep, and pathological. Superficial, deep, and pathological. So superficial is plantar reflex. So may I have answer from any of the student, what is plantar reflex? Jatin Waghela. Jatin, are you there? Jatin has slept. Tejal, rule number 66.
Yes, sir.
Yes, yes, please, Tejal.
Sir, plantar reflexes is when the sole of the foot is stimulated by the an instrument, means hammer.
Very good. Okay, and there will be either greater flexion or extensor. So whenever we are writing plantar
Yes.
reflex, we should write flexor or extensor response. What is abdominal reflex?
Yes. Sir.
Okay,
Sir,
we should,
abdominal
yes,
reflexes.
yes, please.
Sir, stroking
Very
or
good.
abdominal reflex is checked by the stroking on the abdominals.
From lateral to medial or medial to lateral?
Lateral to medial. Yes, sir.
Okay, it is lateral to medial. Okay, very good. If you go from medial to lateral, umbilical deviation may misguide you that reflex is present, but actually it is not reflex. It is because of your hammer movement. But always we should go from lateral to medial. Very good. Cremastic reflex. So scratching over the adductor side of the thigh will elevate the testis. So this reflex will be present only in the male. And corneal reflex. So mostly we are not taking in our stroke patient. But if you stimulate the cornea, there will be blinking of both the eyes. Very good. Okay, good, Tejal. Okay, fine. Now I would like to get answer from another student. So I might have answer from Solanki Lakshmi, roll number 56. Solanki Lakshmi, are you there? Okay, she is busy. Okay, then Prachi Rathod. May I have answer from Prachi? Prachi is also busy in cooking. Keya Patel. Yes, please, Keya.
Yes, sir.
Okay, reflexes. So deep reflexes are, have you taken deep reflexes on any patient?
Yes, sir.
Mm-hmm.
That we check on bicep by hammering on biceps, triceps,
Very good.
on
Very
the
good.
major muscles.
Very good. Bicep, tricep, brachioradialis for upper limb and knee and ankle for lower limb. Clear? So I hope that you all have taken this. And Kaya, can you tell me the gradings of this deep tendon reflexes? Like
Sorry,
1,
sir?
2, 3 gradings. 1, 2, 3, 4, or exaggerated, brisk, normal, likewise.
Yeah. Yes, sir. In that 0 is for no response, 1 is
Very
for
good.
slight response,
Very good.
second is for brisk response, and third is for
Second is normal.
very
Third is exaggerated.
normal.
And fourth is clonus. Okay.
Yes.
Fourth is clonus. Clonus means continuous contractions. Clear? Okay. A few literatures they are classifying up to 4. Few literatures they are classifying up to 5 also. Clear? Okay, good. So I think that this is common. Now the pathological reflexes. So this pathological reflexes will be present only in patients in presence of pathology. Otherwise, they will not be found. So Babinski sign. So it is nothing but same as plantar reflex. But if we are writing plantar reflex, then we should write extensor or flexor response. But if you are writing Babinski, then Babinski sign positive or negative. That's it. Clear? Stimulus is same, response is same. If you have grade to extension, it is Babinski positive. If you have flexor response, it is Babinski negative. Pendular reflex. So the patient will be in high sitting. Okay, you have to imagine. Okay, we don't have any option now. Patient knee will be extended passively. Then you release the patient's leg. Let the patient's leg oscillate. Here, if the patient's leg oscillate, so generally this oscillation will stop after 5 to 6 repetitions. Clear? But if it is more than that, it is suggestive of hypotonicity. If less than that, it is suggestive of spasticity. Generally, 5 to 6, reduced spasticity, increased flaccidity. Clonus. Clonus is nothing but highermost grade of reflex. Clear? So in highermost grade of reflex, the contraction will be continuous. Clear? So madam, may we have Paul now?
Yes, sir. We will. It's 100% results.
Okay, very good. Very good.
Pathological.
Yes, pathological. Okay, fine. Now we are going for tone. So I would like to get answer from student again here. Jatin has not come back. We have called him long back. Jatin.
Yes, sir.
Oh, where are you? You are there.
Yes, sir.
How will you check tone? How will you check tone? Okay. Have you treated any patient of stroke till date?
Yes, sir.
Okay. So how will you assess the tone? Okay, I'm giving you clue. By active
Okay.
movement or by passive movement?
Passive movement, sir.
Passive movement. Fast or slow?
Fast.
Fast. Very good. Tone is always to be checked with fast passive movement. Clear? And the
Okay, sir.
tightness will be checked with slow passive movement. Clear?
Okay.
We have modified Ashworth scale. We have the scale. I'm not going in detail, but simply what I want to clear here, tone is always checked with fast passive movement. There is no any alternate way of assessment. Clear? So based on modified Ashworth scale, you have to grade the tone from 0, 1, 1 plus, 2, 3, and 4. Clear? And it is also assessed with modified Tardive scale. So modified Tardive scale means what? You have any idea regarding this, Jatin? Modified Tardive scale.
No, sir.
Okay, fine. Let me explain.
use टाडू स्केल
Please.
સર ખાલી એટલો આઈડિયા છે કે પીડિયાટ્રિક્સ માં યુઝ કરવામાં આવે.
Okay, good one. Fine. See, many times we have a combination of tightness and spasticity. So modified Tardive scale will help you to differentiate between the spasticity and tightness. Just imagine that elbow is fully flexed. Clear? And I am giving passive movement, fast passive movement. So up to 90 degree, I am able to extend. Then later on, it is not possible. Means it is at fast passive movement. I got R1, that is 90 degree. Then again, the elbow will be flexed fully. Okay, from 140 degree. Again, I will start, but I will start slowly. That is with slow passive movement. Then I will be able to reach up to 45 degree of elbow flexion. Clear? Initially with fast passive movement, I was stopped at 90 degree of flexion. Then with this slow passive movement, I am stopped at 45 degree of flexion, elbow flexion. So it is, we can say that 45 degree to 90 degree, it is also having presence of spasticity, but after 45 degree, it is tightness. Is this clear? After 45 degree, further extension is not possible even with the slow passive movement, so it is tightness. But from 45 degree to 90 degree, it is because of spasticity. And after 90 degree up to 140 degree of flexion, it is normal. Clear? So this modified Tardive scale will help you to differentiate between the tightness and spasticity. Synergy. What is synergy? I would like to get answer from the students. Synergy. Jatin, you be here. I will ask you again.
Yes, sir.
Samir.
Yes, sir.
Yes, Samir. What is synergy?
Sir, flexion synergy and extensor synergy.
That is fine, but what is synergy? Synergy means what? It is mass movement.
Exactly.
Okay. Exactly.
पेशेंट को बोलेंगे कि फ्लेक्शन करो तो मूवमेंट फ्लेक्शन में ज्यादातर होगी।
नहीं, फ्लेक्शन कहोगे तो
ऐसा
फ्लेक्शन
कुछ
में ही जाएगी, पर एक्सटेंशन बोलोगे तो भी फ्लेक्शन में जाएंगी। क्लियर?
हाँ तभी फ्लेक्शन, सॉरी सर। हाँ
If the patient has flexor synergy, so whatever the movement you ask the patient to perform, it will go into flexion of all the joints. Clear? So that is flexor synergy. Clear? It may be extensor synergy also. So the flexor synergy means flexion of all the joints of upper limb. Extensor synergy means extensor of all the joints of upper limb. Generally in stroke patient, most of the patients, they are having flexor synergy only in upper limb. In lower limb, it depends. In non-weight bearing position, flexor synergy will be dominant. In weight bearing position, extensor synergy will be dominant. Clear? Tightness, so as I told you, okay, so that is by slow passive movement. You can check, okay, you all know the stretching, so you can document also. Then range of motion. So I'm not going in detail for range of motion. It is simple goniometry and MMT, that is manual muscle testing. But the MMT is always debatable in stroke patient. So it is better not to take MMT. Okay, if the patient has recovered, patient has no any tonal abnormality, patient has no spasticity, patient's voluntary control is also good, then you can think of getting this manual muscle testing. Otherwise it is not advisable, because the MMT book itself, it tells that in human lesion MMT will not be useful. For that we have different scales. For example, motricity index, so that will be able to measure the strength of the upper limb in stroke patient. So alternatives are available, so don't fall in MMT, otherwise you will be trapped by examiner. Yeah. And then voluntary control. So voluntary control is again debatable topic. So instead of taking voluntary control, I must say that you should go for stream, that is stroke rehabilitation assessment and movement, that I will show you. Okay, I will show you. Then vesting. So vesting is also to be mentioned, like above knee, below knee. This is just example, whatever the centimeters or inches you are measuring for right side and left side, and difference, like 1 centimeter difference on left side. So up to 1 centimeter or 1.5 centimeter it is allowed, but more than that it is considered vesting. Clear? So this should be also mentioned. Now this is original Ashworth scale. We don't need to go in detail. Then this is modified Ashworth scale. So generally we are using this modified. It has one extra component, that is 1 plus. Clear? So 1 plus is addition to 1. 1 means it is end range, we are getting spasticity. 1 plus means it is not completing full range of motion, it is in half range of motion. It is 1 plus. 2, 3 and 4, they are in full range of motion, spasticity is present, means resistance is present. But 2 means the passive movement is easy, 3 means passive movement is difficult, and 4 means the limb is rigid. Okay, limb is rigid. Clear? So this is modified Ashworth scale, generally we are using for assessment of spasticity. This is MMT scale, so that all you know. Okay, then different coordination test we should check. Generally they are not affected
Sorry,
if
sir.
the yes madam.
So can we add one code?
Yes madam, please.
Oh, 55% are telling modified Ashworth scale and 50% both of above.
Okay, so both of above will be correct answer. Okay, it will be useful for tone only. Okay, but still those who have selected modified Ashworth scale, they should also know that modified Tardif scale is also used for this assessment of tone. Okay, fine, good. Now different coordination tests, those should be practiced if you suspect any problem related to basal ganglia or cerebellum. Most of the patients, they might have a lesion in basal ganglia or sometimes even in the cerebellum. See, the patient, if they are having cerebellum stroke, So when you assess those patients by MMT or this strength wise, so they will be normal. They will be having 5 out of 5 power. They will not be suffering from weakness. They will be suffering from ataxia. They will be problem. They will be having problem of coordination. Many patients, they are complaining like this: when I walk, so I'm deviated to left side or I'm deviated to right side. बराबर. एक पेशेंट ने बहुत सरस कंप्लेन करेली. It was a very good complaint that if I'm actually, that patient was farmer, so he was complaining like this, that I feel that my tractor is going to right side, बराबर, if it is having puncture. Clear? Like tractor के कार का તમે ચલાવતો હોય તો એક સાઈડ પંચર પડી જાય તો that will be deviated to that side. Clear? So it is nothing but that type of the cerebellar stroke. So in that cerebellar stroke, you should check this coordination. Clear? Otherwise it is not needed. Now these are the perceptual deficits. Perception means what? So how you perceive this sensory stimuli. See, sensory information will be always in sodium and potassium, but it will be converted into psychological meaningful information. For example, if you have slide in front of you, okay, this slide shows you cat as well as lion. Clear? So when you see this lion, so this information will be received by your eyes, then it will be converted into flow of sodium and potassium only. Then the sodium potassium flow will be again decoded into picture of lion when it reaches to your occipital lobe. Clear? So it is coding and decoding. Like if I talk something from my earphone, okay, so it is my voice, okay, it is meaningful information. Then it will be converted into flow of electrons. That again, this flow of electrons will be converted into same words, whatever I spoke. Clear? So it is nothing but flow of electron will be converted into psychological meaningful information. So that is nothing but perception. Is this clear? So attention, memory, body scheme, spatial relation, agnosia, apraxia, all these are different examples of perception. So let us learn one by one. Attention. What is attention? Anyone? Bharat. Bharat, roll number 11. Bharat, are you there? No. Okay, anyone from students?
So attention means awareness of surrounding environment.
Very good. Very good. Okay, that is whatever you told, that is orientation, Vishal. Okay, attention means we have to receive one stimuli and ignoring other stimuli. Clear? So sustained attention. For example, sustained attention means I am getting information continuously. Like if I'm watching TV or if I'm reading, so whatever occurs in my environment, I'm not focusing on that. I'm focusing only on my TV or I'm only focusing on my reading. Clear? So that is sustained attention, to receive the information continuously. Then selective attention. So I would like to give one example. So many times if you go for prayer, okay, in your college or in temple, so if there are 50 people around you, so if you want to listen to particular individual's voice, then you can attend that voice only. For example, if the 50 people there speak, so in that case, if I want to decide, if I decide that I want to listen to Vishal's voice only, so that will be possible. Clear? So that will be selective attention. Divided attention means I'm doing two tasks simultaneously, like I'm walking as well as I'm talking on mobile. Clear? So that is divided. For example, if I'm taking your lecture as well as I'm checking WhatsApp, okay, so that is best example of divided attention. But actually divided attention, it is recently proved that it is not there. It is shifting from task 1 to task 2 and task 2 to task 1 very fast. Okay, but as per our book, we will consider that divided attention is ability to perform two tasks simultaneously. Alternating attention means, as I told, from task 1 to task 2, task 2 to task 1. For example, if anyone is cooking, so she might be cutting vegetables. In between, she will be stirring something on the stove. Again, she will be cutting vegetables. Again, she will be stirring something on stove. So that is example of alternating action. Okay, fine. Now, body scheme and body image, unilateral neglect. Okay, can anyone tell me? Nancy. Nancy.
Yes,
What
sir.
is unilateral neglect? Yes, unilateral neglect. No idea? Samir. Samir Patel. Okay, Samir. Yes, Nancy, please.
સર એક્ઝેક્ટલી નથી ખબર પણ એમાં એક સાઈડમાં બોડીમાં એને ખબર પડતી હોય.
Okay, very good. Good. Okay, fine. Let me explain. Patient will ignore one side of the body. Patient will ignore one side of the body. Like if I am giving a task of drawing a circle, he will draw only half. If I tell to wear the pants, so he will put both of his legs into one part only of the pant. Okay, if you give something to it, so only the half dish will be eaten, otherwise it will not be eaten, it will be left. Why? Because it is not existing for him. Clear? So that is unilateral neglect. Best example or best assessment is to ask the patient to draw a clock. Then anosognosia. So the person will deny to accept the disability. Okay, so that is anosognosia. That patient will not accept that I am suffering from all this disability. Somatoagnosia. So patient will not be able to answer his body parts. Like this is elbow, this is finger, this is head. Okay, either on body or in the figure also, or on therapist body. Patient is unable to name them, okay, or able to identify. Right left discrimination, so patient will be confused for identification of right and left side. Clear? So all these are problems of body image. Those will be part of perceptual dysfunction. Now spatial relation. So patient will be having problem in figure ground discrimination. So especially that can be best assessed with buttons. Like for example, I have blue shirt and blue buttons. So it will be very difficult for me to identify the exact location of buttons. Figure is not separated from ground. Clear? Then form discrimination. Form discrimination means if the two objects of same shape will be put together, like brush and pen, toothbrush and pen, patient will be confused. Or if object is in awkward position, like generally water jug, so we always see it in vertical position. If it is in horizontal position, patient will be having problem in identification. So the patient will not be able to identify the exact shape. Okay, so that is form discrimination. Now the spatial relation and position in space, they're almost similar. Spatial relation means it is in contact, and position in space, that is without contact. For example, if I'm sitting here, so I can see that fan is nearer as compared to tube light, or tube light is far from fan. Okay, so that is nothing but position in space. Topographical disorientation. So we all have suffered from this topographical disorientation when we visit any new multiplex. Clear? If I go to any new multiplex, I need to ask, where is the toilet, where is the bathroom, okay, where is the screen one, where is the ticket window? So that is topographical disorientation. Then depth and distance. So I will be having problem in ascending and descending steps. Or if I want to pour the water into the glass, okay, from RO filter, if I want to fill the glass, so I will not be able to identify that whether this glass is full or not, and ultimately it will overflow. And then vertical orientation. So whatever it is vertical, it should be vertically seen. But many patients, they seen it somewhat inclined. So what happens when they pass from the narrow passage or narrow door, they will incline their body to one side. Why? Because for them door is inclined, it is not vertical. Clear? So all these are spatial relations, those we need to assess, but it will be assessed only if you suspect any perceptual disorder. Then agnosia. Agnosia means your sensory system is intact, but as we discussed, the interpretation is not done. Clear? For example, if I have, if I have a laptop in front of me, okay, so my eyes are normal, my optic tract, optic chiasma, optic nerve, all are normal. They all are sending this information to occipital lobe. But this occipital lobe is not able to convert this sodium potassium flow into the psychological meaningful information, that is picture of laptop. Clear? So definitely I can say that I'm suffering from visual agnosia. Similar is applicable for color, auditory. Clear? Auditory means, for example, if I speak something like stroke. Clear? So my ear will listen, it will also send impulse from vestibulocochlear nerve to the brain, but brain will not be able to decode it. Okay, so this sodium potassium flow will not be converted into exact word, that is stroke, that should be interpreted at brain level. Okay, tactile means it is related to touch in the same way, and for fingers also in the same way. So agnosia means patient is not able to convert this sensory information into psychological meaningful information even in the presence of normal sensory system. Clear? Apraxia. Apraxia means it is inability to perform the skillful movement. Idiomotor means the patient will not be doing it by anyone's order, but if the patient wants to do, patient will do. This is the best explained in the movie Gajni. Okay, though in that the hero actor Amir Khan was doing everything what he wanted to do, but if someone tells him, okay, that you click my photograph or you come in bus or come with me, so he will not follow. But if he wants to does, okay, if he wants to do, he will do. Clear? So on command patient will not do, but patient will do with will or his own volition. Clear? So that will be there. Then ideational. So on command also he will not do, and on patient's on volition also will not do. Clear? So you can say that it is idiot. Idiot means, okay, they don't want to do. Okay, if you explain them, okay, they don't understand, and by themselves also they don't want to get understand. Clear? So it is idiot or ideational type of apraxia. Clear? So idiomotor means on command it will be done, but not by volition. Ideational means, okay, it is not at all. Clear? Okay, then balance. So balance will be checked in sitting as well as in standing. Static balance and dynamic balance in both. So there are multiple scales for balance, but it is better to go with Burke balance scale. And if your clinical purpose is only there, then you can also rely on functional balance scale. Okay, so these are the functional balance scales. It is normal, good, fair, poor, and nil. All these are given in Sullivan. Okay, so you can memorize this. And for static, this is for static. In the similar way, it is for dynamic. So nil means it is absent, and normal means it is normal. So this is in descending order. As you go from higher side to lower side in the slide, balance decreases. But better is to go with Burke balance scale. Okay, so that is gold standard. Okay, now gait examination, that should be also done. So first thing is to be seen whether patient is able to walk independently or patient needs some assistance like walker or stick. Generally stick uses more as compared to walker, because for walker we need two upper limbs normal, and it is very common that this hemiparetic patients, they are also having problem in upper limb grip, especially grip is weak, so holding walker will be difficult. Most of the patients will be having stick on normal side, so that should be mentioned. And we should also assess the step length, step width, step length, stance times, and cadence. Generally the step length is more with affected side, and it will be less on normal side. Why? Because the patient will be always having fear to go for stance phase on affected side. Okay, so opposite side, that is normal side, will not be in swing phase for more time. Clear? Because patient will be afraid of fall. So swing phase will be more on affected side. but it will be less on normal side. Okay, so step length will be more on affected side as compared to normal side. Okay, step width, so that will be identifying the wide base of support or narrow base of support. Similar way for stride length. Stance time, so as we discussed, that will be different because of fear. Okay, patient is having fear to bear more stance on affected side. And cadence, so generally up to 110 or 120 cadence is fine. Cadence means it is steps per minute. Clear? So that should be assessed. These are the stride length and step length example. Clear? So stride length means it is the linear distance between the two successive events of same extremity, and step length means it is the linear distance between the two successive events of two opposite extremity. So step length is between right and left, and stride length is between left and left or right and right. Yeah, likewise. Now this is the last test that you can perform, but generally clinically, frankly, if I tell, nobody is doing this. Sweat function test is one of the powder that will be spreaded over the patient's body, and when it comes in contact with this sweat, it will change its color. Okay, and another is galvanic resistance test. Yeah, so just by the presence of sweating, you can identify the resistance. Functional assessment. Clear? So for functional assessment, generally why the patients are coming to us, they're having some issues with their function. Like, I'm not able to comb my hair, I'm not able to dress myself, I'm not able to drive my vehicle. Okay, I'm not able to eat by myself. Okay, I'm not able to take care of my home. So all these are functional problems. Those should be assessed. Clear? Simply you can ask these questions. Okay, or you can have different scales also, like FIM, that is functional independence measure, and Barthel index, and generally we use nowadays modified Barthel index. Clear? And this is disability assessment. Most of the time you might have presented your case with ICIDH2. So impairment means it is at personal level. So if I talk of the stroke patient, infarct size in MRI, infarct location, presence of spasticity, pain in shoulder, all these are impairment. So they are at organ level. Then activity limitation, so that is at personal level. Like activity limitation means I'm unable to go for overhead movement, for combing, dressing. Okay, so it is at my personal level. I'm unable to walk, so that is activity limitation. And finally, it is participation restriction. Participation restriction means at society level. Because of stroke, the person is not able to continue the job. Because of stroke, patient is unable to go for social functions like marriages and birthday parties and other parties. Okay, so at social level, patient's participation will be restricted. Something that will help to overcome, that will be your facilitator. For example, patient uses stick, so that will be facilitator. And something will be barrier also, like steps, okay, uneven surface. Okay, so all these are examples of barriers. Clear? And I'm showing you few scales for more 5-4 minutes. And if you want to attend more lectures by me, just search my name in YouTube and you will be getting the list of lectures. Okay, so as per today's topic, it was stroke assessment. So you all have learned this. Okay, and I would like to show you just overlook of the scales. So one is BBS, that is Berg Balance Scale. It is gold standard scale for assessing balance. So that can be used for your stroke patient. Okay, it has total 14 questions, and each question will carry maximum marks of 4. So if you have normal balance, your total score will be 56. Okay, so this is Berg Balance Scale. You can have notes in your book. So there are total 14 questions. It is very easy. Okay, just ask the patient how the activity is written, give your instruction, and whatever the patient is able to do, whatever it is matched with the patient. For example, for my patient, able to lift leg independently and hold for more than 3 seconds when the patient was told to stand on one leg. Clear? So you just put here. Okay, so there's 2 score. So in the similar way, you can have all the assessment, okay, and total. So generally more than 40 score will be good. Less than 40, so patient has chances of fall out of 56. Then Kuppuswamy scale. So that is for socio-economical condition. See, socio-economical condition, it is many times subjective. Like if I say that my socio-economical condition is good or poor, it differs from person to person also. If someone is asking me to borrow money, then I will tell that I have poor socio-economical condition. I don't want to give money. If I want money from someone, okay, then I will be okay. Or if I want to impress someone, I will be telling that I have very good socio-economical condition. So that is subjective. But this Kupuswamy scale will make it possible that out of maximum 29, okay, you can have this look. Okay, all these are available online, okay, on Google. But if you know the name, you can search. Okay, that is my objective. So Kupuswamy scale will be having this type of the classification: upper middle, lower, and even lower, upper, lower. Clear? So whatever the score you are getting, okay, based on that, you can have idea about the patient's socio-economical condition. Then modified Barthel index. So feel still somewhat subjective. Functional independence measure. Barthel index is having maximum score of 100, but nowadays what is used is modified Barthel index. Okay, so this is just have a look on modified Barthel index to assess the patient functional status, and you have interpretation here. Out of 20, if the score falls below 15, patient has moderate disability, and if it falls less than 10, it is severe disability. Clear? So you just mention or this names. Otherwise, you can find everything on Google. But again, you need to give proper keywords to Google. Okay, then mini mental state examination. So this is having total score of 40 for cognition assessment, and minimum score should be 24. If the patient's minimum score is 24 or more, then you can that assess patient properly. Otherwise, the patient will not be able to cooperate with you for your assessment. Clear? Many times you may be asking to your teachers that this patient is not giving proper answer. Whatever I'm asking, he is giving different answer. So the possible reason is having reduced score of MMSE, mini mental state examination, maybe 23 or less than 23. So those patients will not be cooperative. Okay, then Fugel-Meyer. So it is given in Sullivan, Fugel-Meyer motor assessment score. So you just go for it, Fugel-Meyer. So total is 226. It includes upper limb, lower limb, sensation, balance, pain, range of motion. So I can say that if you go for Fugel-Meyer scale, no need to assess anything else. Just you go for Fugel-Meyer. Okay, that will assess all the components those may be affected in stroke. Clear? Okay, then stream. I told you stream, stroke rehabilitation assessment of movement. See, voluntary control assessment is always debatable in stroke patient, whether it should be checked position wise, movement wise, is not clear yet. So better to go with stroke rehabilitation assessment of movement. Okay, and finally you will be having score. Okay, and this can be compared with further score. Like for example, this sheet has 4 dates. I'm checking on 1st November, then I'm checking on 15th November, then I'm checking on future dates of December. Okay, likewise, and I can compare the difference. Okay, this component has improved in voluntary control. And last is stroke impact scale. Now whatever we do, okay, whatever we do, but if the patient is not having satisfaction, it is useless. Okay, so this is the scale to be filled by patient. All previous scales, those are to be filled by therapist. This is the scale to be filled by patient of stroke. Yeah, so how they are perceiving. For example, if I am the patient, so I will read one question, that arm that was most affected by your stroke. So how I perceive it? Okay, 3. Okay, it is having some strength. If someone is having with negative impact or with negative personality or depression, so they will write 1 only. If someone with very positive thoughts, they will write, okay, lot of strength I have. Even in the presence of having, they will give grade 5. So how the patient is perceiving himself, yes, that will be assessed by stroke impact scale. Clear? So I think that I have made it clear for you people. Okay, and I would like to further hand over to Madam
Yes.
Suthar, Madam.
Yes, sir. Sir, thank you so much. Very nicely explained whole the assessment. Really.
Okay. And have
Excuse
students
me,
have.
sir.
Yes, madam. Please, madam.
Yes. Any questions?
Please, madam.
Sir, this is Pallavi, one of the staff members from the college.
Yes, madam.
Sir, actually, can you please just explain the sensory examination little bit in detail, as the students still have dilemma like in what way they should examine, whether it would be dermatomal, nerve wise, or homunculus.
Okay, very good. It is very good question, madam. Generally, for CNS disorder, it is not compulsory to go dermatome wise. Okay. See, in neuro, it is not mentioned anywhere. But if it is PIVD or if it is nerve injury, then we can think of dermatome wise distribution. But in this, we cannot go dermatome wise. If we assess as a whole, that is also fine. But for that, if it is the question persisting, and for the safer side, if the student wants to on safer side, so in that case, you can go with the sensory component of Fugel-Meyer scale. Fugel-Meyer assesses upper limb, lower limb sensation, balance, and pain, and this range of motion. So it is better to go with sensory examination component of Fugel-Meyer. And component wise also, it is proved that it can be used. So as per my opinion, we should go with sensory examination component of this Fugel-Meyer, or else we can go without dermatome. It is also fine. And as a teacher, we should also accept it if the student has not done dermatome wise. But definitely in lower motor neuron lesion, it should be dermatome wise.
Yes.
Over
Okay,
to you,
sir.
madam.
Okay.
I hope that you are satisfied with the answer.
Yes, sir. Actually, students are were in the dilemma, like they were like whether to take dermatomal and like that way. So I thought that I only asked the question so that their doubts get
Yes,
solved.
madam. So in short, if we summarize, element lesion dermatome wise, human lesion, it is fine. We should accept without dermatomal distribution.
Yes, sir. Yes, sir.
Okay, madam.
Any questions from students? Students, is it audible to everyone?
Students, they are hungry, I
Yes.
think.
Yes, sir.
They are hungry.
Might be, sir. Any questions? No? It's clear? Whole
Okay.
stroke assessment? No questions?
Madam, I think that we should show some dinner dishes in front of the
So,
students.
so they can answer it.
Yes.
Yes, sir.
Okay.
Okay.
Okay. And I would like to thank Jasprit madam and Suthar madam again, and for this wonderful audience. So thank you so much, madam. Thank you so much.
Ma'am is here. Just
Yes,
wait, ma'am.
madam.
Yeah. Thank you, Dr. Ashish. It
Thank
was on a very short notice you accepted our invitation. And this is a great insight for them, a basic insight which I believe is very much important for a physiotherapist.
Okay,
Because
madam.
we daily assess stroke patients in a whole lung. So they don't know what is happening and how to assess. That really affects the rehabilitation protocol. So your short and sweet presentation, I think, will help them to move on further. And basically, what I wanted was a functional scale, which you really mentioned for them. That is was a wonderful task. So thank you so much for being there for us. Thank you so much.
Thank you, madam. Thank you, madam. Madam, I have tried my level best to explain, but some things, you know, that it will not be possible if I don't have patient in front of me. But still, I have tried my level best. Thank you, madam.
Yes.
Thank you, sir.
No,
Very
no, I can
nicely.
understand it. It would have been better if we could have made it more hands-on, but I can understand that right now we are on the verge where the pandemic made us
Yes.
to be more of online ones.
Yes.
But
That is
still, I think you've passed on great knowledge to them, which if they, even if they take that 1% of this, they'll be able to do wonders with this.
Thank you, madam. Thank you, madam.
Thank you so much, sir.
Thank you, sir.
Thank you, madam.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay.